So it's my pleasure to introduce our very first presenter, Sigil Maya, who's going to be talking to us about optimal strategies to screen healthcare workers for COVID-19, a cost-effectiveness analysis.
Thanks for the introduction, Madhvi, and good morning, everyone. To start off the day, I will be talking about the cost-effectiveness of COVID-19 screening strategies for healthcare workers, like Madhvi mentioned. Next slide, please. So as we all know, COVID-19 has affected so many aspects of all of our lives, but we wanted to focus specifically on the healthcare worker population because they have more frequent and higher risk contact with COVID-19 patients. So they may be a vulnerable population in this context. Our initial theory is that if we strategically assign presumably immune healthcare workers to COVID-19 units, then we would reduce transmission in the healthcare setting and avoid subsequent transmissions that may occur in the healthcare workers' communities. Next slide, please. Sorry, I forgot to set my timer. So the screening strategies we considered included two different COVID-19 tests. First, we have the PCR test. Briefly, the real-time polymerase chain reaction tests look for specific sections of viral RNA, but they don't distinguish between active transmissible virus and non-infectious viral fragments left behind as the infection is clearing out. And as a result, an infected individual may remain PCR positive for over a month, but evidence suggests that they're not really contagious after about 8 to 11 days after symptom onset. Next slide, please. On the other hand, we have the IgG immunoassays, and these tests look for antibodies against SARS-CoV-2. That tells you if you have ever been infected, but it is not yet clear if this means you have conferred immunity. Next slide, please. So given all of this, we wanted to find out how to best use these available tests to inform workforce management decisions. Specifically, we decided on 5 testing approaches that I will talk about in a minute and evaluated the health outcomes, the net costs, and the cost effectiveness associated with these tests. We then made some recommendations based on those assessments. Next slide, please. So we built a decision model-based cost effectiveness analysis to answer these questions. The testing approaches we compared were no testing, administering 1 PCR test, administering 1 IgG test, administering both tests together, and administering a PCR test only if the IgG test came back positive. Next slide, please. Okay, but the human body is not static, and so the markers these tests look at change over time. And to account for this, we stratified our population of healthcare workers into 3 major groups based on the presence and history of flu-like symptoms. First, we have early clinical disease, which is further divided into 2 groups, those who are 1 to 7 days since post-symptom onset and those who are 8 to 14 days post-symptom onset. Then we have the late clinical disease, so more than 14 days after symptom onset. And finally, asymptomatic healthcare workers who may or may not be infected. Next slide, please. Here's a simplified version of our model. First, we have our inputs defining the population, and then we choose one of the 5 options. After this, we input a series of probabilities. For these kinds of analyses, it works best when you start with true disease status, which is unknown to the individual. So that's what we did. We began with the probability that our healthcare worker is either susceptible to the virus, is infected, or has recovered and is not infectious anymore. Now, this does not necessarily mean that they have clinically recovered. They may continue to have symptoms, but it just means that they don't have any viable virus remaining. And then each of these arms further branch out as the healthcare worker either has antibodies or they don't. And finally, given each of these conditions, we determine the likelihood of getting a positive or negative test result, or a combination of test results if more than one was done. Let's take a look at the outputs now. Next slide, please. Based on the test results that they receive, healthcare workers undergo some sort of behavior change. They may isolate, they may be more likely to get assigned to COVID-19 cold zones where they care for only non-COVID-19 patients, or they may be more likely to get assigned to COVID-19 hot zones where they exclusively care for COVID-19 patients. And depending on what behavior they undertake and their underlying disease status, the model calculates the number of new infections acquired, an estimate of quality-adjusted life years lost, and the total cost of screening and treating the subsequent infections. Next slide, please. Here are outcomes for no screening and PCR screening for a healthcare worker who started having symptoms less than 7 days ago. We have the health outcomes at the top and the cost outcomes at the bottom. With no screening, there is about 2 new infections acquired per healthcare worker not screened, which leads to 0.14 QALYs lost, and $6,000 in treatment costs are incurred due to these infections. But no implementation costs arise because we didn't do any tests. On the other hand, if a PCR test screening were to be conducted, we would have only a fifth of the new infections and the QALYs lost, and treatment costs would also be much lower, but of course we would have some additional costs of testing. Next slide, please. Here's the cost effectiveness results for screening healthcare workers at this stage. As you can see in the top row, PCR testing is the best way to do it. It leads to the fewest new infections and thus the fewest QALYs lost, and it also costs the least, making it the dominant strategy. All other options are dominated by this. They are more expensive and less effective. Screening healthcare workers 8 to 14 days post-symptom onset and screening asymptomatic healthcare workers gave similar results. We conducted multivariate analyses and saw that these results do not change substantially even when we generously vary the most uncertain inputs. So next slide, please. So this is for asymptomatic healthcare workers, and as you can see, there are a lot fewer QALYs and costs at stake, but the outcome is the same, and PCR testing dominates. Next slide, please. But then things really start to change when we're screening for healthcare workers who started having symptoms more than 15 days ago. PCR testing drops to the last row now. It's no longer dominant. And in fact, it's even worse than doing nothing at all. This is because at this time, the model is interpreting positive PCR tests as false positives because it's unlikely that someone is still infectious even if they did have COVID-19. So when someone who was in truth susceptible receives this false positive test result, they are thought to be recovered and they start taking more risks. But with no test, everyone acts as if they're susceptible. And assuming that full immunity is conferred, only IgG testing is the dominant option here, confirming our initial thoughts that we can in fact reduce transmission by assigning healthcare workers to care for COVID-19 patients. Next slide, please. So the sensitivity analyses for screening in the late clinical stage were the most significant. It turns out that IgG testing is not always dominant. This is the result of a Monte Carlo simulation with 10,000 iterations, which is a multivariate analysis. And this probability distribution shows that conducting no tests saves more QALYs than conducting an IgG test in over 70% of these simulations, indicating that it is dominant in these cases. Next slide, please. So here we can see what's driving this change. This is a tornado graph showing the effect of key inputs on QALYs saved with no test. As you can see from the wider bars at the top, this outcome was most sensitive to immunity conferred and prevalence of COVID-19. These cause the most variation in QALYs saved. Next slide, please. I want to talk a little more about immunity. We get a perfectly linear relationship when we look at the effect immunity has on QALYs saved with no test compared to IgG testing. At around 70% immunity conferred, no test starts to be more beneficial than IgG testing. Now keep in mind that while true immunity conferred may be low, around 70 or 60%, the healthcare workers in our model are still operating under the assumption that they're fully protected. And this discrepancy between our understanding and the true characteristics of immunity is what's driving these poor health outcomes. Next slide, please. So to bring it all together, we found that PCR testing is the best option when screening healthcare workers who are asymptomatic or very recently symptomatic. Adding antibody testing to this, or especially conducting only antibody testing, generates false reassurances of recovery, leading to healthcare workers taking more risks and increasing transmission. This highlights the need to really scale up PCR testing to improve precision and get results faster. On the IgG side, many serological studies recommend using these tests at around the 3rd week after symptom onset because the detection rate of these tests really increase at that time. Our findings agree with this recommendation, and we also find IgG testing to potentially be an effective approach only in later stages of infection. But while antibody testing is crucial for epidemiologic or seroprevalence studies, using them for policy decisions may have unintended harmful effects until we have a greater understanding of COVID-19 immunity. Next slide, please. So an important limitation of our study is that most of our key inputs were based on highly uncertain estimates. While we did our best to make sure that they were reasonable and conducted extensive sensitivity analyses, looking ahead, our assumptions and inputs need to be reviewed and updated as the research grows. We also have compared a limited number of options, so if and when new testing methods become available, those should be incorporated into this model to make comparisons that are as realistic as possible. And last but not least, adapting this analysis to different settings, especially different COVID-19 hotspots experiencing resource deficits, is important to achieve the best use of resources in these settings. Next slide, please. I want to finish by thanking our entire study team, as well as the 203 team for all their support, and of course our healthcare workers who have been fighting this pandemic on its front lines for months. Next slide, please. And with that, I'm happy to answer any questions you may have.
Thank you, Sigil. That was outstanding. And thank you for your patience through the slides. Apparently an auto timer got turned on, but our colleague Rohan is going to fix that for the next presentation. In the meantime, while we await some questions and answers from the audience, I wanted to just ask you, how would you recommend we act in San Francisco or in California in terms of requesting routine or scheduling routine testing for healthcare workers?
Yeah, I think PCR testing is really important. It's really important to detect who's possibly a threat to the other healthcare staff or the patients there that are non-COVID-19. So that's really important to identify those and isolate them. On the IgG testing, it really depends on how much we believe in immunity is truly acquired, because this is a method that, as Dr. Rutherford pointed out previously, it's been used for Ebola, it's been used for other diseases, but we don't really know yet what's going on with COVID-19. So I think we need more information before we can say something about that for sure.
Great. I'm sure I'll have more questions, but I see that there may be some available. Will our course assistant team read the next question for us?
I don't think we have a question yet. We just have a comment from Neelam Feacham that you gave an outstanding presentation.
Thank you.
Well, then,
sorry, there's one question that just came through right now from Dr. Sepulveda. Dr. Sepulveda also said great presentation and asked why use QALYs instead of DALYs.
Yeah, that's a good question. It doesn't really make that much of a difference. They're the same order of magnitude. They're just in opposite directions. So it's a preference thing. And in this case, it was also a data availability question. We had an estimate of QALYs lost per COVID-19 death. So that's why we went with that for this analysis.
Sigil, while we're waiting for some additional questions, I think one of the elements that you talked about was your Monte Carlo simulation, and just the idea, the potential for us to get a better understanding of what parameters were most significant in this situation. And I'm sorry if I missed this, but talk to me a little bit more about what role prevalence rates have on your model, and a little bit about how that relates to what our prevalence rates look like, let's say in the United States or California.
Yeah, so when we're looking, all of those sensitivity analyses I showed were for the late clinical disease, because in the other ones there weren't that much of a difference that I could show. But in the late clinical disease, what's driving the new infections is the susceptible individuals acquiring infections, because we're assuming that everyone's recovered, nobody can infect anyone else at that situation. So it's only those who are susceptible. So if we have a high prevalence of COVID-19, then we have fewer individuals who may acquire the disease, and therefore spread is less. But if we have a lower prevalence of COVID-19, that leaves a larger proportion of the population susceptible. So that's why you get more new infections in that case, because you're also assuming that they've recovered. So they're taking more risks as well.
Thank you. That makes a lot of sense in terms of understanding those, what factors you had to change in order to look at what the outcomes might be, or the cost might be. It looks like there may be no additional questions, and I know this might be biased by the fact that we had the opportunity to hear from Sigil and our next presenter last week, so I think a lot of people had the opportunity to ask questions then. Yeah. But outstanding job, congratulations. And we're really excited for hearing the next presentation, which is also very relevant to this topic. Okay, our next presenter is Guntas Pada, and she's going to be talking to us about cost effectiveness. I'm sorry, it looks like we have the same issue, but we'll work on that too. Evaluating the cost effectiveness. Give me 1 second here. Everyone, please be patient with us as we work out this online webinar. Give us just 1 more minute here. Do we lose this? Okay, we're back. Thank you, Guntas, for your patience. So this is the next presentation by Guntas Pada, talking about the cost effectiveness of COVID-19 screening in the workplace. Go ahead, thank you.
Thank you so much, Madhavi. Hi, everyone. My name is Guntas Pada, and my Capstone project evaluated the cost effectiveness of COVID-19 screening in the workplace. Next. So as we all know, the ongoing COVID-19 pandemic has forced many industries in the United States to temporarily shut down workplaces. As states across the country begin to gradually reopen their economies, many industries are seeking safe and effective strategies to return to work. While the CDC and OSHA both call for health screenings in the workplace, neither jurisdiction specifies the optimal screening modality to be used. Thus, there's minimal government guidance over this topic. Next. So my research question sought to mitigate knowledge gaps associated with the implementation of COVID-19 screening in the workplace. My aims are to define methods of screening for COVID-19, to estimate the cost and health outcomes associated with screening methods, and finally, to estimate and compare the cost effectiveness of screening methods. To answer my research question, I constructed a cost effectiveness analysis and modeled the ability of screening methods to detect COVID-19 along with their costs of implementation. Next. Here is an overview of the decision tree I used to model the health and cost outcomes of COVID-19 screening. Our population of interest is the general workforce in California. Workforce members were assumed to have 1 of 3 COVID-19 infection states, susceptible, infected, or recovered. Each infection state is associated with varying probabilities of displaying symptoms, which then have varying probabilities of being detected by the 5 screening tools listed in the decision column. Based on the infection state of an employee and the diagnostic accuracy of the screening tool at hand, 2 actions were possible. Individuals could be flagged as a suspected case and instructed to isolate, or they could remain an unsuspected case and continue working with standard COVID-19 precautions. Based on these actions, the number of infections transmitted and the cost of isolating employees from the workplace was estimated. Next. So now let's take a look at the screening interventions considered. First, I looked at daily self-reported symptom questionnaires. This type of screening is cheap to implement, and employees can use their own smartphones, tablets, or computers to fill out the screen. This tool is limited in that there is no standard questionnaire, and questionnaires can vary widely in content. Also, the estimated test performance of this tool is limited by the self-reported nature of the answers. Next. I next considered fever screening with non-contact infrared thermometers. These thermometers have a fairly large price range, with price usually increasing as precision increases, and they've also been shown to have quite large variations in test performance, particularly in their sensitivities. Next. Fever screening can also occur with infrared thermal image scanners, which have a relatively high sensitivity and specificity. However, the cost of this tool is limiting, with the price ranging from $3,000 to $8,000. Next. Next slide. Oh, sorry, previous slide, thank you. The final option I considered is weekly infection screening with PCR tests of nasopharyngeal swabs. PCR tests have a relatively high test performance, although it is limited by the sample quality and time frame. Another limiting factor is the high cost of PCR tests. In California, each test can cost between $100 and $800 due to the high rent rates of testing sites. Next. So as I've just shown, screening methods have varying costs and varying propensities to detect the symptoms they are intended to measure. Another factor that impacts the effectiveness of screening methods is the prevalence of COVID-19-like symptoms in our population. Each infection state in the model is associated with varying prevalences of COVID-19-like symptoms. What I'd like to point out here is that only about 60% of COVID-19 cases are estimated to display symptoms. The high prevalence of asymptomatic carriers here is what ultimately compromises the ability of symptom-based screening tools to detect COVID-19 cases. Furthermore, COVID-19-like symptoms are not limited to COVID-19 cases. Uninfected individuals can display symptoms that overlap with the disease and can be flagged as a suspected case. Next. So the study setting here is defined as having low to medium risk for COVID-19 exposure. So high-risk settings, such as healthcare settings, are excluded. For the purpose of this presentation, I will focus on a workplace scenario of 100 employees in an office-based environment, though the model can be applied to a variety of settings. This analysis assumes that standard COVID-19 precautions are in place, in particular personal protective equipment and 6 feet social distancing. Another assumption is that individuals who are flagged as suspected COVID-19 cases will be instructed to isolate from the workplace and follow up with a PCR test, with their return to work being contingent on a negative PCR result. Finally, the analysis assumes that isolation from the workplace results in some degree of lost productivity, which ranges from 10 to 100% in the analysis. For this presentation, I will use a base case of 50% lost productivity. Next. Based on the diagnostic value and behavior changes associated with each screening intervention, health and cost outcomes were estimated. The health outcomes are the number of infections transmitted in the workplace and community and the associated QALYs lost, and the cost outcomes are the costs of testing, lost productivity, and treating new COVID-19 infections. Next. So PCR screening resulted in the lowest number of new infections and QALYs lost. In our company of 100 individuals, about 3 infections would be generated in the time frame of 1 month. This result reflects the ability of PCR screening to accurately detect and isolate COVID-19 cases compared to other screening methods. However, it also demonstrates the limited capacity of our most accurate method, as a moderate number of infections are still permitted. Next. PCR screening also demonstrated the highest positive predictive value. In other words, it had the highest ratio of true COVID-19 cases to suspected COVID-19 cases. Having a high positive predictive value is advantageous for companies because fewer falsely suspected cases are instructed to work remotely. Thus, there's a lower associated reduction in overall company productivity. The high positive predictive value of PCR screening largely drives our cost results. Next slide. So net costs were estimated for each screening strategy. The first column displays the per day cost of implementing each screening tool. This takes into account the purchasing price of the tool, the cost of a human resource to operate the tool if needed, and the cost of buying additional PCR tests for all suspected cases. The second column displays the cost of lost productivity associated with isolating suspected COVID-19 cases. Tools with lower specificities have higher costs in this column because a greater number of employees are falsely categorized as having COVID-19 and are asked to isolate from the workplace. The third column displays the cost of treating new COVID-19 infections in each screening scenario. Overall, PCR screening is the second cheapest option to implement. Now, total cost here is partly driven by the cost of medical treatment for new COVID-19 infections, and this isn't necessarily a cost that would be considered by employers because this would largely be covered by insurance. Next slide. However, even if we take out the cost of COVID-19 treatment, PCR screening remains the second cheapest option to implement for an employer. Next. To determine the cost effectiveness of the screening options, incremental cost effectiveness ratios were constructed. PCR screening was found to be cost effective compared to no screening at about $57,000 per QALY gained, and the dominant option compared to the other 3 screening options. Next. So to summarize the findings, weekly PCR screening is a cost-effective option for screening employees, and symptom-based screening is insufficient to prevent the widespread transmission of COVID-19 in the workplace. Next. Sensitivity analyses were conducted on a number of data inputs. One key sensitivity analysis that I'd like to share today is the effect of company closures on company productivity. For some work environments, a workplace shutdown results in very little lost productivity. However, in other environments, shutting down the workplace really compromises the ability of the workforce to do their job. My analysis demonstrated that when very little productivity is lost due to remote work, it's actually more expensive to keep the workplace open and implement screening. In these scenarios, it makes sense to shut down the workplace. However, at higher reductions in productivity, it's more costly to shift to remote work. It's in these scenarios in particular where PCR screening is a strong option to keep the workplace open. Next. Although this analysis demonstrates the cost effectiveness of PCR screening, it doesn't necessarily demonstrate its feasibility. My analysis focused on weekly PCR screening because this was deemed a pragmatic timeline given resource constraints around PCR tests and lab processing. However, if PCR tests were made more accessible and affordable, more frequent testing could occur. This, along with improved test performance, would limit the number of new infections permitted by the screening strategy. Another opportunity to make PCR screening more accessible is by removing the need of a health professional, such as with self-swabbing kits. Next. I will finish with some limitations. The limitations associated with my analysis are largely due to widespread knowledge gaps associated with COVID-19. As longitudinal studies are made available, it will be crucial to update my analysis with more accurate numbers. In particular, my analysis relied on 2 studies reporting antibody seroprevalence from Santa Clara County and Los Angeles County, both of which were published in April. These studies have been criticized for overrepresenting COVID-19 prevalence, so the prevalence estimates in my analysis are likely an overrepresentation. Next. Finally, I would like to thank my mentor, Dr. Khan, and my entire research team for supporting me throughout this capstone project. And a big, big thank you to the 203 team and to my entire cohort. Congratulations. Thank you.
Thank you so much, Kuntas. Excellent job and really a nice fit with the previous presentation. Both of you are answering some really important questions or putting out some information I think that will help decision makers make those difficult decisions about whether to keep workplaces open, when and how to screen. While we wait for some additional Q&A questions, I wanted to ask a little bit about the results of the PCR testing. I'm sorry about the sound in the background. Can you tell me a little bit about whether or not you think there is an element? So the PCR test, if I looked at it correctly, had a positive predictive value that was around a little under 50%. Is that correct? Were you, or and maybe I misunderstood that, but were you able to get a sense of what would happen in terms of cost if the predictive values were variable or were even better if we were to get better testing, for example?
Yeah, so one thing I will point out is that so positive predictive value for PCR screening was highly dependent on the prevalence of COVID-19 in the population. So at very slight increases in the prevalence of COVID-19, the predictive value really jumped up for PCR screening. So at higher positive predictive values, the cost of, in particular, of isolating suspected cases goes down because at that point, whoever you're flagging as being a suspected case, there's a high number in that group that are actually infected. So you're not falsely isolating anybody. So that would drive down the costs associated with PCR screening.
Thank you. That's really helpful. I think there may be a question or a comment.
We have a question from Dr. Rutherford asking whether you could address the effect of delays in returning PCR results, and is it worth it for companies to invest in point of care testing?
Absolutely. So my analysis assumes that individuals will not be able to return to work until a negative PCR result is obtained. If it takes 7 to 10 days for that result to be known, that's highly ineffective. Companies should absolutely invest in point of care testing. And I think that's a matter of making PCR testing more affordable and accessible. This also can tie into the fact that I looked at weekly PCR screening when ideally we would want daily PCR screening if you really want to accurately keep a track of infections in the workplace. So making PCR screening occur more rapidly, more inexpensively would really, really make this a more effective method.
And we have another question from Neelam Feacham saying, excellent presentation, and also asking, do we have any real life examples of companies who are doing this or are considering doing this?
So off the top of my head, I don't know of any companies doing weekly PCR screening besides in healthcare settings. I know a lot of places doing symptom-based screening and hope that my analysis has highlighted some of the constraints associated with this screening strategy. So yeah.
Another question from Dr. Sepulveda asking, given the current estimated prevalence of COVID-19 in California, would you be able to do a cost effectiveness analysis solely for our state?
I definitely could. What's great about the structure of the model is that at this point, it's a matter of inputting different data inputs, and that can be applicable into different scenarios. I think what would be difficult about doing a cost effectiveness analysis for the state at this point is just recognizing the heterogeneity between different regions in California. I think what's happening inland is different than what's happening in the coasts, and even what's happening in the Bay Area is different than what's happening in Los Angeles or San Diego. So that would be a limitation associated with doing a statewide analysis, but it absolutely could be done.
That's all the questions we have in the chat thus far.
Great, thank you.
Well, thank you so much, Guntas. Really excellent job. I do think that this, for both of you, this is so timely and relevant that I hope, and I think your team is supporting you to get the information out there as soon as we can. But I love the idea that Dr. Sepulveda provided of local level analysis, either at the state level or even, as you mentioned, in specific regions like our 6 Bay Area counties, that might be really helpful to guide decisions around testing, especially because we also have to grapple with the concern about access to adequate testing materials, which I know is a concern certainly in our county right now. Great, thank you so much.